ومبسوطه اني
دكتورة كريمة
شفتك يا شيرين.
منورانا والله يا فندم.
الله يكرمك يا حبيبتي، الله
يا رب
يكرمك.
دايما معانا وما يحرمناش منك ابدا.
تعيش يا حبيبتي تعيش، ربنا يبارك فيكم. اتفضلوا.
دلوقتي احنا هنقدم مجموعه من الكيس سيناريوز والبيتفول، وات وير ذا بيتفول في الحالات ديت، وهيقوم بتقديم الحالات يعني جيل الشباب بتاعنا المشرف الناهض في الوحده الاساتذه المساعدين، وهتقوم الاستاذه الدكتوره داليا حلمي الغنيمي بالتعليق عليه والكومنت على كل حاله. طبعا يعني دكتوره داليا غنيه عن التعريف، استاذه
ربنا يكرم حضرتك يا رب.
وهي يعني لها نشاط واضح وعلامات مميزه في الوحده بتاعتنا الحقيقه. ويعني هي انا مش هقول هي عضو في الايسيد وعضو في الواو وعضو في البرنتو وعضو في الجمعيات العالميه كتير، ولها ابحاث كتير منشوره بره، وبشجعها اكتر انها تنشر كمان وكمان. دلوقتي اول حاله هتقدمها لنا هي الدكتوره ربا الجويش، وهي الدكتوره ربا مدرس مساعد عندنا. هم الحقيقه كل المدرسين المساعدين بتوعنا انا بعتبرهم ابطال، ويعني بيحاربوا في جبهات كتيره في المناعه الحساسيه ونقص المناعه والروماتولوجي، ودايما متميزين ومتالقين. ودلوقتي هنستمع للدكتوره ربا الجويش تقدم لنا الحاله الاولى. اتفضلي يا دكتوره ربا. ربا معانا؟
جزيلا. ايوه يا دكتور، شكرا جزيلا لحضرتك على التقديم، وربنا يعيننا دايما ونكون عند حسن ظن حضراتكم. السلام عليكم اساتذتي الكرام، زملائي وضيوفنا الاعزاء. Please allow me to present our first case scenario. A 10-year-old girl was diagnosed with acute follicular tonsillitis, for which she was prescribed ceftriaxone intramuscular injection that she received at a near pharmacy and then left. 10 minutes later, she was flushed and had deep cough. She rapidly developed generalized urticaria and itching. The parents went back to the pharmacy, where the pharmacist gave her intramuscular hydrocortisone and oral antihistamine, reassured and sent her home. On their way back to home, the girl felt chest tightness chest tightness, and the parents rushed to the emergency room at a near hospital. When arrived to the emergency room, she felt dizzy and her blood pressure was 80/50 millimeter mercury. The parents told the resident that she received ceftriaxone intramuscular injection 20 minutes ago. He gave her epinephrine, 0.1 ml subcutaneous, and intramuscular hydrocortisone. The girl didn't improve, with evidence of respiratory distress, and her blood pressure dropped to 70/40 millimeter mercury. Heart rate was 130 beats per minute, respiratory rate 40 breaths per minute, and oxygen saturation 89. She was then admitted to the pediatric intensive care, where she received slow intravenous epinephrine infusion and intravenous isotonic saline with rapid fluid bolus. She was given high flow oxygen by face mask and inhaled salbutamol. 3 hours later, her blood pressure increased to 90/60 millimeter mercury, with improvement of her skin and chest symptoms. She became stable and was discharged 2 days later. Thank you.
Thank you, Dr. Roba, for your clear presentation for the first case scenario. Now we will discuss the pitfall in diagnosis and management of the anaphylaxis in this girl. From the presentation of this girl, she has skin and chest symptoms which indicate anaphylaxis triggered by ceftriaxone, and presence of acute follicular tonsillitis might act as a cofactor that amplify her hypersensitivity reaction to the ceftriaxone. So what about the first aid management she had received? We found that the pharmacist gave her intramuscular hydrocortisone and oral antihistamine. Moreover, he reassured the parents and sent her home, which is completely wrong and major mistakes. The pharmacist actually was not aware of the clinical criteria to diagnose anaphylaxis, so he did not recognize that the girl had anaphylaxis triggered by the ceftriaxone, and hence he gave her hydrocortisone and oral histamine, commonly used to treat other allergic disease. And that's why we always ascertain that anaphylaxis should be known by every physician, moreover, the allied health professionals, and we should even raise the awareness of the public about this life-threatening situation. Coming to the second, we found that at the ER, the resident diagnosed anaphylaxis. He gave her epinephrine 0.1 ml, which is a very low dose. The girl is 10 years. And moreover, he gave her a subcutaneous because he was afraid of the adverse effect of the epinephrine. And he saw that if he gave intramuscular hydrocortisone, it will act together. However, this was not the case, and the girl did not improve with evidence of respiratory distress, and her blood pressure dropped more to 70/40, heart rate 140 per minute, and she was tachypneic with oxygen saturation dropped to 89%. Epinephrine should be injected by intramuscular route in the mid-anterolateral sign, the vastus lateralis, as soon as anaphylaxis is diagnosed or strongly suspected in a dose of 0.01 milligram per kg of a concentration 1 to 1,000 to a maximum of 0.3 milligram in children. And we saw how the WOW anaphylaxis guidance, beautifully illustrated by Dr. Ilham, show algorithm for giving the epinephrine as a rapid way of calculation according to the age of the patient in the pediatrics age group. So coming when she entered the ICU and she received slow intravenous adrenaline infusion, she was okay and she's improved. But is it all this story as they discharged her after 2 days, just telling the parents to avoid ceftriaxone? Actually, this is not the case. Treatment of anaphylaxis does not end with the resolution of the acute episode in a healthcare setting. There should be provision of the patient, caregiver, education, and training about recognition of anaphylaxis and when and how to inject epinephrine with personalized written action plan in case of recurrence. Moreover, a medical identification card to document that the patient is allergic to ceftriaxone in order to use alternative in the future as much as possible. Referral to allergist is very essential to evaluate possibility of cross-reactivity with other generation of cephalosporin if they share the same R-sided chain with the ceftriaxone and penicillin for regular assessment. Now we'll go to the second case presented by Dr. Rana Zakaria.
يا رنا.
دكتور رنا.
احتمال رنا عامله ميوت للميكروفون يا جماعه.
دكتور رشا ممكن حضرتك تعملي unmute all وبعدين بعد كده لما تبدأ رنا.
حاضر حضرتك اللحظة دي اهو. وانا مش شايفه رنا معانا فممكن نعمل شيفت. طيب الكيس اللي بعدها الكيس اللي بعدها لحد ما
دكتوره داليا تقدم الحاله. الحاله عشان الوقت.
طب نعمل سكيب للحاله حضرتك عشان لو رجعت نقولها ولا ايه؟
طيب قدمي الحاله يا داليا عشان.
طيب. Second case, a 14-year-old girl who had severe sesame allergy was at the airport with her parents and asked for cheese sandwich. They read the ingredients of the sandwich and found sesame is not written. 15 minutes after the girl took 2 bites from the sandwich, she was flushed and developed urticaria. She had severe colicky abdominal pain and wheezy chest. She had her epinephrine auto-injector and was injected rapidly by her father. 5 minutes later, her symptoms were improved and she became stable thereafter. The parents revised themselves again and went to read the ingredient of the sandwich again and found that a word till was overlooked. And when they Googled it, they found it stands for sesame. And this exposed her to a life-threatening anaphylaxis. So what about the pitfall in case 2? That these parents and the girl, they actually read the food labeling, but when they didn't understand the meaning of the word, they overlooked it, considering it not important, and she ate the sandwich. But after the attack, they Googled it and found it stands for sesame, and this was a major mistake. Sesame is a common trigger of anaphylaxis in the Middle East. However, sesame ingredient can be listed by many uncommon names like till, fenniseed, gingerly oil, gomashu, which is sesame salt. Therefore, it is very important that sesame should be written in plain language to be understood by the publics. So it's very important to always advise the patient caregiver to read the food labels and ask questions about ingredients they didn't know before eating a food that they have not prepared themselves. This is very important. So coming to the third case by Dr. Mustafa, we'll listen to him now.
مساء الخير، أنا مصطفى الأمين، مدرس مساعد بوحدة الحساسية والمناعة للأطفال. هقدم الحالة دي دلوقتي. A 10-year-old boy felt dizzy and flushed nearly 30 minutes after joining a volleyball match. He rapidly felt chest tightness and severe colicky abdominal pain. The match was suspended, and the doctor accompanying the team made him stay in a semi-sitting position and found his blood pressure to be dropped 80/54. He was tachycardic, heart rate 120 per minute. He gave him rapidly 0.3 ml of IM epinephrine, and few minutes later, the boy improved and became stable. The doctor asked the parents about previous similar attacks, and his father reported that he experienced a similar attack 2 weeks ago while they were running together, but the previous attack was milder and he spontaneously improved. The doctor asked the parents to avoid exercising for fear of life-threatening attacks in the future.
So thank you, Dr. Mustafa. So what about the pitfall in this case? The doctor managed properly the boy who was standing, so he let him to stay in a semi-setting or in semi-recumbent position because he had chest tightness and evidence of somehow respiratory involvement, and he gave him the epinephrine intramuscular appropriately, and the boy recovered. But about the management, he asked the parent to avoid exercising for fear of life-threatening attack in the future, and this is completely wrong and will induce anxiety in the patient and his family. Exercise is not contraindicated in patients with exercise-induced anaphylaxis. Therefore, the doctor should have clearly instructed the patient and parents instead about measures to prevent recurrence, which include strict avoidance of relevant co-triggers like intake of food or non-steroidal anti-inflammatory drugs at least 4 hours before exercising. Avoid exercising under ambient conditions of high humidity, extreme heat, or cold or high pollen counts. Never to exercise alone. Carry mobile and epinephrine auto-injector if not available, a 1 ml syringe filled with the correct dose of epinephrine according to his weight. Patient education to discontinue immediately exercise when feeling first symptoms of anaphylaxis. So this is how to deal with exercise-induced anaphylaxis, and never to forget to ask about intake of food near exercise. The last case would be presented by Dr. Noha Abdessalam. Please proceed, Noha.
مساء الخير. السلام عليكم أساتذتي وزملائي الكرام. I'm going to present the fourth case. A 5-year-old boy who had bronchial asthma presented to the ER with generalized urticaria, angioedema of the face, wheezy stress, and evidence of respiratory distress. The mother reported that few minutes after her son ate 2 pieces of kiwi, he became flushed with intense itching and then other presenting symptoms to refill. The resident gave him 0.15 milli IM epinephrine. 10 minutes later, his skin and chest symptoms were greatly improved and he was observed for 1 hour, then discharged. The mother was advised to avoid kiwi. 2 hours later, the boy was brought again to the ER because of being drowsy and recurrence of his symptoms. His blood pressure was found to be 70/40 millimeter mercury, heart rate 160 beats per minute, respiratory rate 48 breaths per minute, and oxygen saturation was 90%. He received 2 doses of intramuscular epinephrine 5 minutes apart, IV isotonic saline, rapid bolus, and was given high-flow oxygen by face mask. An inhaled salbutamol by nebulizer was continuous monitoring. He was then improved and became vitally stable. His parents decided to take him to his treating allergist.
Thank you, Noha. Now we find that the patient already has a risk comorbid disease, which is bronchial asthma, and he has ESPAI allergy. And the doctor diagnosed that it is anaphylaxis and treated him the first aid properly by giving him the intramuscular epinephrine. But however, he observed him only for 1 hour. Although there is no consensus on the duration, the patient with anaphylaxis should be monitored after apparent resolution of the symptoms. However, because of the risk of biphasic anaphylaxis, which can occur within 1 up to 72 hours after the initial symptoms, but usually within 8 to 10 hours, it is therefore recommended that patients with moderate respiratory like this boy actually had as well bronchial asthma or cardiovascular compromise, like the patient is hypotensive, severely tachycardic, should be monitored for at least 4 hours. And if indicated, it can extend up to 8 to 10 hours if it was severe. So what about the discharge of this patient? He was just discharged and the mother was just told to avoid kiwi. If that's what he already needs. Actually, no. As we can see with the first case, this patient did not receive a discharge management plan, including the parent education and training. And this is very important because this is a food allergy and this is a young child that can be exposed accidentally to the kiwi. He should advise the mother for strict avoidance of the kiwi and give him a medical identification card, like Dr. Ilham kindly said, like a bracelet to identify that this patient has a kiwi allergy till further evaluation by the allergist. So as we can see in these cases that we need to raise awareness of the physician health, allied health professional about anaphylaxis, to know very well that giving the appropriate dose of epinephrine by the appropriate route, inshallah, will not be hazardous, but instead it will save the life of the patient. Early treatment will prevent further progression of the anaphylaxis to distributive shock and irreversible shock. Patients should be monitored, not to allow them to leave from the ER once they are improving. And thank you for your attention, and I would like to acknowledge my professors and my colleagues in the Pediatric Allergy, Immunology and Rheumatology team founded by Professor يحيى الجمل اللي افتقدناه جدا، بس نتمنى ان كل علم يا رب يبقى في ميزان حسناته. وبشكر جدا يعني اساتذتي دكتوره زينب، دكتوره شيرين، دكتوره إلهام وزملائي جميعا for their support and continuous support. وجودهم بس الحمد لله نعمة في هذه الوحدة. شكرا لحضراتكم جدا.
شكرا يا داليا على الكومنتس الجميلة، وأنا الحقيقة فخورة وسعيدة جدا بأولادي الدكتورة نهى والدكتور مصطفى والدكتورة رنا. الحقيقة كنت وربا، الحقيقة كنت يعني كلكم ممتازين. أنا مبسوطة بيكم جدا وفخورة بالتقديم بتاعكم. وليا كلمة واحدة بس عايزة أقولها، إن فعلا what we need is to raise the awareness not only among physicians، لأنه physicians they need awareness, they are within reach ان احنا نقدر نوصل لهم. but we need to raise the awareness among the public. يعني المدرب الرياضي، الفارماسيست، الناس اللي في البيت، حتى ممكن يكون اهل الطفل نفسهم لما الدكتور يقول لهم اخرجوا يقولوا لا ازاي؟ احنا سمعنا ان الانافيلاكسس بيقعدوا فيها up to 10 hours او up to 1 day في المستشفى. فدي الحقيقه نقط مهمه جدا جدا لازم يعني تو ستريس عليها. وان شاء الله باذن الله الجمعيه بتاعتنا تعمل بروشورات تتوزع على البابليك، ممكن في المدارس للمدرسين المدربين الرياضيين. طبعا not to mention ان الليبلينج of food ingredients is very important. احنا في مصر هنا عندنا lack of labeling بكل اشكاله، وحتى فعلا لما بيكتبوا حاجه المفروض يتكتب ان ده الحاجه دي جايه اصلها من السيسمي مثلا زي الحاله بتاعتنا، او في بعض الاحيان تلاقيهم كاتبين شورتنينج، ما انتش عارفه ده الشورتنينج ده هو عباره عن ايه في البسكوتات بالذات والحاجات اللي هي الويفر وكده. فدي مهمه جدا ان الليبلنج يبقى واضح جدا علشان الناس اللي عندها ألرجي تبقى واخده بالها ان الاكل ده ممكن يعمل مشكله. دلوقتي انا بدعوكم معاكم لأستاذة الدكتورة رشا حسن العويدي. دكتورة رشا يعني دي بنتي الجميلة، وأنا ببقى فخورة بيها جدا في كل المحافل الدولية. هي عضو في الإسيد وعضو في الأسد، وهي عضو ناهض جدا في